All right, well, it looks like we've hit a steady state, so perhaps we can get started. Welcome everyone to Cardiology Grand Rounds. A special welcome to our fellowship candidates. We're delighted to have Dr. Reshad Garan present at Grand Rounds today, and Dr. Gersten will be introducing him.
Thanks. Well, it's a real pleasure to introduce Reshad, who originally hails from actually Newton, Massachusetts. He traveled across the country to go to college at Stanford, and then returned to the East Coast to do medical school and his residency training at Columbia. He joined the faculty there in around 2011 or 2012 and really rapidly garnered an intra-institutional reputation as a real emerging leader in heart failure. And while expert in all aspects of heart failure, he has a particular interest in cardiogenic shock, as we're going to hear today, the interface of hemodynamics and emerging ventricular assist devices, and is now the author of on over 100 manuscripts. And recognizing his immense talents and leadership capabilities that, to me and Peter, really exceeded the bounds of his own institution, we were very fortunate to recruit Reshad 3 years ago or thereabouts to lead our heart failure section. And along with an extraordinarily deep team of collaborators and physicians in that group, including Doctors Will Grandin and Marwa Sabe and Pablo Quintero and Lisa Fleming and Shweta Motowala and their team, he and they together have built a really outstanding program and firmly planted the flag, I think, on the national scene with an eye towards developing a world-class heart transplant program in the very near future. So Reshad, take it away. Thanks for giving Grand Rounds.
Thank you very much for the kind introduction, and thank you to Arthi for the invitation. Definitely want to welcome our applicants. I'm going to be talking about cardiogenic shock in 2021. Have we changed the outlook? Here are my disclosures. I am going to be presenting data from the Cardiogenic Shock Working Group, which I will spend some time at the end of the talk describing a little bit more, but it's essentially a rapidly growing academic research consortium focused on generating data in shock so we can actually move the field forward. I'm going to briefly touch on some important changes over the last couple of decades to the CCU demographic, and then talk about how understanding the etiology of cardiogenic shock really should dictate how we think about the different patients that we're treating in the ICUs. I'm going to touch on some improvements in risk stratification that have been relatively recently proposed. I'm going to highlight a few of the recent publications and randomized trials that really, I think, are important steps forward for the field in general. And then think about, because of the difficulty that we've had in general completing randomized trials, ways that we can try to move this field forward and really think about the development of randomized trials that we'll be able to complete so we can inform the practice. We'll start off with changes in the demographic. So this is a snapshot of the CCU patient, from several years ago. And as it should not be surprising, the majority of patients in the CCU who are being treated for shock those are cardiogenic shock patients. But what's important to note on the right is that the etiology of cardiogenic shock has shifted really over the last several decades. We're seeing less and less patients that are being treated for cardiogenic shock as the result of an acute myocardial infarction, and more patients with chronic heart failure who decompensate and present with shock in particular, but other forms of cardiogenic shock are becoming more and more commonplace in our ICUs. This is data from Germany, which essentially shows similar trends. You can see on the left that the percentage of patients with AMI-related shock is slowly decreasing over time. Meanwhile, patients presenting with non-ischemic or other forms of cardiogenic shock is slowly increasing. And interestingly, we actually see a rise in the incidence of cardiogenic shock, I think this has a lot to do with the fact that our treatments for earlier forms of cardiovascular disease have improved. So patients are living longer, but eventually develop end-stage disease and present particularly decompensated with shock. There's some interesting trends in the utilization of mechanical circulatory support throughout this time. What we see is relatively stable utilization of mechanical circulatory support device over the last decade plus, but the types of devices that are being used have differed. So interestingly, we see a decline in the utilization of the balloon pump, and at that same time, rising use of ECMO and other devices like Impellas. Now, unfortunately, we have not seen a dramatic change in the mortality for these patients. And this continues to be one of the deadliest conditions that we treat in medicine. So having recognized the fact that the CCU patients that we're taking care of have really started to change, I think it's important to highlight some differences between the different types of cardiogenic shock that we treat. Now, these are data from a large registry. This is the CardShock registry in Europe, which encompasses, patients with AMI-related shock or acute coronary syndrome-related shock, but also other non-ischemic etiologies of shock. And you can see here that those two patient populations, at least in terms of early prognosis, appear to be very different. The odds ratio of in-hospital mortality from shock related to an ACS etiology is more than sevenfold. And when you look at these early curves with respect to outcomes, patients with ACS-related shock seem to be behaving very differently than those, again, albeit with a relatively small non-ACS related cohort. They seem to be behaving quite differently, at least in the early outcomes. We've also learned a lot about what drives outcomes in these distinct patient populations. So one of the most well-cited papers from the Cardiogenic Shock Registry and Trial really focuses on hemodynamics and what hemodynamics in an AMI patient population dictate outcomes. And the emergence of flow-related indices like the cardiac power output and cardiac power index as primary drivers of early outcomes in AMI patients with shock really, I think, focused the field on those flow-related indices. But when we turn to patients with chronic heart failure who present decompensated and in shock, we see that actually different hemodynamic parameters are driving outcomes. So this is a recent publication from the Cardiogenic Shock Working Group, which includes both AMI-related shock patients and decompensated heart failure-related shock patients. And we examined the value of what we call a stress blood volume. Now, stress blood volume, you can think of blood, or volume as having two components: the unstressed blood volume, which is essentially the volume of blood in vessels that fills the vessels but is not enough to distend them. Whereas the stress blood volume is the amount of blood, or that volume of blood, that begins to distend vessels. And the pathogenesis of worsening heart failure and decompensation really begins with mobilization of that stress blood volume into the vasculature that begins a downward spiral for that patient. And what we saw when we examined this particular value is that it really had little impact on outcomes when we examined patients with acute AMI-related shock. But when we examined patients who presented with decompensated heart failure in shock, we saw that that particular hemodynamic variable, or that volume, really was one of the major determinants from a hemodynamic perspective of short-term outcomes. And so what dictates outcomes in one patient population does not necessarily dictate outcomes in other forms of cardiogenic shock. What we've also recognized is that the way that we judge success, or we view success for these two distinct patient populations, looks different. On the left, these are data from a small pilot study that I was involved with in New York, where patients presenting in shock, and these were patients with SCAI classification C, D, or E shock, and I'll talk about the SCAI staging system briefly in a little bit. Yeah, but those are relatively sick shock patients. They were treated either with Impella or ECMO as first-line therapy. And the differences between the devices is not what's important here, but what is important is that in an AMI shock patient population, even for the sickest patients, the majority of survivors had ventricular recovery. And I think anybody treating an AMI shock patient is really focused on survival, but obviously with ventricular recovery, so that patient doesn't necessarily need bridge to left ventricular assist device therapy or a transplant. When we deal with a patient population of long-standing chronic heart failure who decompensates and presents in shock, success looks very different. So of the same sort of severity of shock patients in the cardiogenic shock working group, again, the outcomes look different, the survival looks better, but more than half of those patients ultimately needed either bridge to left ventricular assist device or transplant for survival. And I think any of the people who are used to treating this patient population, who are dealing with sick patients in the ICU and are able to bridge those patients to a ventricular assist device or a transplant, they would all consider that a huge win for the patient. Whereas I would say that's less so for patients with AMI shock. Obviously, again, survival, I think, is obviously what we're trying to target here. But we really are focused on ventricular recovery in the AMI patient population. And many of the patients with decompensated heart failure are bridging instead to those other therapies. Now, I touched briefly on the pathogenesis of heart failure-related shock. We all know, the classic, downward spiral, the paradigm of the AMI shock patient population, where there's obviously a systolic insult that begins a downward spiral and rapidly leads to the patient expiring. But the pathogenesis of really the transition from chronic stable heart failure to end stage shock on multiple pressors, a device, a circulatory support device, and being intubated in the ICU, as I mentioned before, really begins with venous congestion. We have many patients in the heart failure clinic that have a big dilated ventricle and yet are stable outpatients, doing well, functional, but it's really that venous congestion that begins the transition from stable outpatient to critically ill patient in the ICU without much change in ventricular function, obviously. And why is it important to highlight these differences? When we think forward to therapies that we ultimately hope to be able to offer this patient population, what we understand about the effect of one therapy in a patient with AMI-related shock should not necessarily be extrapolated to have the same outcomes in patients with decompensated heart failure-related shock. So we all know the punchline of the IABP SHOCK 2 trial, which randomized patients with AMI-related shock to early balloon pump use or standard therapy. There were some major concerns about crossover in this trial, but at the end of the day, I think everyone understands that there was essentially neither benefit nor harm for that patient population when it comes to balloon pump utilization. But I don't know that we can say the same thing about patients with chronic heart failure who present in shock. So this is a hemodynamic analysis of patients in the ICU in New York, where we took care of a lot of these patients, and we examined the acute hemodynamic effects of aortic counterpulsation, balloon pumps, in patients with AMI-related shock and heart failure-related shock. And we saw some important differences. When you look at the AMI cardiogenic shock patient population, it begins to shed a little bit of light on the null findings of the IABP SHOCK 2 trial. There was minimal change in cardiac output or index. There was minimal effect on SVR in that patient population. And when you look at instead the hemodynamic effects acutely for balloon pump in patients with cardiogenic shock, but suffering from chronic heart failure, the effects look very different. Again, not necessarily what you would expect with some of the more powerful devices, but certainly a more robust augmentation of cardiac output and cardiac index, and a more robust reduction in systemic vascular resistance. Now, I'm not saying that a randomized trial in patients with decompensated heart failure related shock and balloon pump would necessarily be positive, but I think it's fair to say we can't necessarily extrapolate the results of IABP shock 2 to a distinct patient population with a different underlying etiology. And some partners in Italy are actually testing this hypothesis. They're taking patients with chronic heart failure who present in shock manifested as hypoperfusion of end organs, and actually randomizing them to early balloon pump utilization versus standard vasoactive therapy. As with many trials in this field, enrollment for this patient population continues to be difficult. There are people who feel that balloon pump should go into every patient like this. There are people who feel that it has no role. Hopefully, as a community, we can come to some agreement on where there is equipoise. But I think it's important to remember that what results we get from a randomized trial in one distinct subgroup of shock patients, again, should not necessarily be carried forward to be truth in all patients with cardiogenic shock. So next, I want to touch on some improvements in risk stratification, because in order to really conduct trials that I think we need to get the answers for this patient population, I think we need to be better at understanding risk profiles in cardiogenic shock. So up until relatively recently, I think the field with respect to risk prediction in cardiogenic shock has been very, very difficult to interpret, as opposed to the Apache score, the SOFA score, scores that are more widely used in patients with general ICU patient populations, with a lot more traction in that population. When it comes to cardiogenic shock and risk stratification, the field is much more confusing. This is from a recent review that one of my colleagues performed of really all of the risk scores that have been proposed over the last largely 20-30 years in cardiogenic shock. A lot of them have focused exclusively on AMI related shock. But even with that, and the fact that there are relatively little data to help us risk stratify patients with heart failure related shock, when you look at the scores that have been proposed, there are so many different factors that are incorporated into these risk scores that I think it's fair to say we really don't have a great sense of how to actually predict risk in this patient population. I will say that when it comes to risk scores, as a clinician, I think the most valuable contribution of risk scores, at least in the at the bedside in the ICU, tends to come from actually a futility score when it comes to this particular disease process. I showed you the mortality a couple of slides ago, which continues to be very high. And so I think our instinct is to try to be aggressive and try to offer interventions that may help the patient. But I do think as a field, it's important to recognize that there are some patients that we are actually not going to be able to stabilize and that will likely die no matter what we do. And I think to recognize that and to recognize when a circulatory support device is more likely to prolong the dying process than actually provide meaningful chance of survival is an important thing for us to accept. And in particular, to then actually avoid escalation of therapy and even think about pursuing de-escalation for that patient population. Now, I want to touch on the SCAI staging classifications. I mentioned this a couple of slides ago, but this is a relatively simple classification, but I actually think it's a big step forward for our field in general. So the classification really stages patients and tries to capture their trajectory more than anything. There are less details about, particular lab values or hemodynamic variables, or even what the underlying etiology of shock is. And it simply tries to get a good sense of what's that patient's actual trajectory in shock. Are they beginning? Are they classic? Are they starting to deteriorate, or are they in extremis? And again, although very, very simple, I think this has actually allowed us to begin to speak the same language when we start thinking about this patient population. And so in that, to that end, I think that's a big step forward. So we can start to actually think about how we might randomize patients with this relatively heterogeneous condition. So that staging classification has been applied to more and more CCU patient populations. This was one of the first analyses which applied the SCAI stages to a single academic center, but a very large CCU patient population. And you see that these stages, correlate very nicely with short-term outcomes. And again, this is not necessarily unexpected, but it is nice to see that at least we have, I think, a baseline that we can start to actually refine risk prediction from. We performed a similar analysis with the cardiogenic shock working group, which again includes patients with AMI-related shock, with decompensated heart failure-related shock, and actually other etiologies of cardiogenic shock. And we sort of mapped each patient profile to these stages and saw that, again, this staging classification very nicely correlated with in-hospital mortality. But more importantly, it didn't really matter whether patients were suffering from MI-related shock or heart failure-related shock. The staging classification continued to help us risk stratify those patients, at least in a retrospective nature, irrespective of the underlying etiology. So as we have really focused, again, particularly in the cardiogenic shock working group, on that patient population with decompensated heart failure-related shock, it has really not been the focus of any of the sort of high-quality data that has been generated in this field. We're starting to see some important differences. I wanted to highlight a couple. This is, again, an analysis of that patient population in particular. And we're starting to see some differences here in what predicts risk of in-hospital mortality for patients with heart failure when you're looking at what has historically predicted risk in patients with AMI-related shock. So I mentioned filling pressures, but in particular, right atrial pressure seems to be a very powerful driver, or at least something that associates very closely with in-hospital mortality in this patient population. Elevated serum creatinine should not come as a surprise, but one of the important findings is that elevated bilirubin. Again, this is a chronically diseased patient population, and these other markers of really more, I think, acute on chronic end organ hypoperfusion are starting to emerge as powerful predictors of risk, particularly in the heart failure related patient population. The more we focus on understanding the impact of filling pressures, the more I'm really impressed, with by the impact of particularly a biventricular congested profile. Again, these are data, sort of a hemodynamic analysis and associations with early outcomes in the cardiogenic shock working group, and in particular in the heart failure patient populations. Signs of right ventricular congestion or biventricular congestion really are harbingers of poor outcomes. And not surprisingly, the sicker the patients get into the stage D and E phases of shock, we see more and more of those patients having really a hemodynamic profile of biventricular congestion. Now, I've sort of gone through, I think, the strengths of the SCAI staging classification. I do think it's important to note that it is relatively simple. There's a lot of value in it, but I do think we can actually improve upon risk stratification. And this is an analysis that we did in the cardiogenic shock working group, where we did, we performed a machine learning algorithmic analysis of patients in that data set. And what you see are in the cardiogenic shock working group, which we used to derive phenotypes of shock, we really see, based on consensus k-means clustering, that the best fit is really 3 distinct phenotypes of cardiogenic shock. And you can see over here on the right that these phenotypes tend to cluster pretty well. We then validated that clustering in patients from a separate registry. This is actually a large registry of cardiogenic shock patients from a Danish registry. And we see nicely that that distinct patient population also seems to cluster nicely based on these phenotypes. And I forgot to mention, these phenotypes are largely based on a combination of hemodynamic and biochemical variables for patients sort of at their admission and identification of cardiogenic shock. And we saw that those 3 profiles correlated nicely with short-term outcomes in hospital mortality. Those 3 profiles really we described as a first profile or first phenotype of a non-congested patient population, but with evidence of a low output state. So really hemodynamic compromise, but without congestion yet. The second profile was one of sort of the cardiorenal phenotype, and patients where a low output state resulted in early signs of renal hypoperfusion. And then a third profile, third phenotype of really a more diffused shock state, where lactate is going up and we see more diffused end organ hypoperfusion. And while this is not, in retrospect, this should not be a big surprise to anybody in the audience. I think what is important to recognize is that when you actually apply these 3 phenotypes to patients in similar stages within the SCAI staging classification, you begin to see some heterogeneity. And so when you think about, in particular, SCAI stage D, patients that are deteriorating, and I think patients where a lot of the interventions that we think about need to be focused to determine whether they're going to actually change outcomes, I think it's important to recognize that not all those patients are necessarily the same. There are patients that, in profile 1, in phenotype 1, that have a relatively good prognosis and may not actually, have any derived benefit from some of these more invasive therapies. Whereas there are certainly some patients that I think, as I mentioned before, when there's evidence of really multi-organ failure and significantly elevated lactates, those are patients that I think we are also unlikely to change the trajectory of, unfortunately. But it's that middle group, that cardiorenal profile, where I think we should be focusing on within these SCAI staging classifications to really actually test in a randomized trial fashion, is intervention X of benefit to this more clearly defined patient population with this devastating illness. So I do want to touch on a couple notable randomized trials that are very recent. And again, I'll talk about ways that we need to move the field forward after this, but I do think it's important and really important to commend the authors of these trials, if nothing else, then for the fact that they were able to complete a randomized trial in cardiogenic shock, which has been historically very difficult. So this is sort of hot off the presses. This is the DOREMI trial. Actually, one of our fellows is Jeff Marbach in the cath lab, is one of the co-authors on this trial. This is a pragmatic trial. This was a trial where a single center in Canada randomized almost 200 patients with SCAI staging, stage B through E cardiogenic shock, really from any etiology, with a primary composite outcome of in-hospital death from any cause, resuscitated cardiac arrest, transplant or utilization of an assist device, non-fatal MI, stroke, or initiation of renal replacement therapy, and randomized them to dobutamine or milrinone as a first-line inotrope. And I think the punchline here obviously is that there was really no difference with respect to the primary composite outcome. But I think one of the most important things to note about this trial is that the investigators actually completed a randomized trial in cardiogenic shock, which is certainly a difficult feat. And so I think that is a reminder to this field that when trials are designed appropriately, we can actually complete them. Going to sort of the other end of the spectrum in this disease process, this is the ARREST trial. And this is also really a remarkable feat that the investigators completed this trial. This trial randomized patients with ongoing CPR to a strategy of early ECMO initiation or standard ACLS algorithms. And they were able to enroll 30 patients in the middle of a global pandemic. And again, assigning half the patients to early initiation of ECMO, half to standard resuscitation treatment, and looked at a primary outcome of survival to discharge. There were a number of important exclusion criteria to note here. Anybody who had an anticipated transfer time to essentially the cath lab where this therapy would be initiated was excluded. Blunt penetrating trauma victims, anybody with evidence of active bleeding, drowning, overdose, any chronic residents of a nursing facility, anybody who had chosen to request an opt-out study bracelet. Again, these were patients who had out-of-hospital cardiac arrest. If the cath lab was unavailable, there were a number of exclusion criteria here. But after 30 patients, this trial was stopped early, because they had already crossed their threshold for termination. And you see here, in the patients with standard, resuscitation, CPR, ACLS algorithms, one patient out of 15 survived to discharge and unfortunately passed away following discharge about 3 months later. There were 6 patients out of the 14 that were ultimately analyzed in the early ECMO arm that survived to discharge. And I think more importantly, actually had good neurologic outcomes at 6 months. And again, so this trial was stopped early. It demonstrates that when rigorously applied, this therapy, can have dramatic effects. I would obviously caution that, these are not necessarily, broadly applicable data. This basically applies to patients that have an out-of-hospital cardiac arrest within 30 minutes or less from an ECMO-capable center that has a highly coordinated collaboration with emergency medical services, the cath lab, and systems that are really used to using this therapy. So again, an important message, less generalizable, but again, I think important to recognize that a very difficult trial to conduct was completed and seen through, to the final results. This is a figure from a very nice review on cardiogenic shock that Holger Thiele published a couple of years ago. And this basically outlines what we have learned from randomized trials, at least in the AMI shock patient population. And you can see here, there are a number of sort of important, I think, areas that we are focused on: revascularization with shock trial and culprit shock, vasopressor and inotrope utilization, anticoagulation and antiplatelet strategies, other interventions, balloon pump, mechanical circulatory support devices. And when you sort of look at this, you realize with these trials, we have not identified a whole lot of clear and convincing therapies that provide benefit to this patient population. And when you look at the trials that, at least at this time, had been completed in blue on the left, and were ongoing and still are ongoing in many instances on the right, you start to understand this landscape better. So obviously we talked about the SHOCK trial, IABP SHOCK 2 and culprit shock, which all met their enrollments and completed their trials. There are, more than that, a number of trials that were either underpowered from the start or had to close early because they simply could not recruit patients and randomize patients for these interventions. There are a number of ongoing trials in this field. I want to highlight 3 over towards the right here. The first is the ECLS SHOCK trial. The second is the EuroSHOCK trial. These are both European trials where patients with AMI-related shock, again, all still focused on AMI, but AMI-related shock patients are randomized to early ECMO utilization versus standard therapy, obviously with revascularization as well. And both of those trials are en route to enroll more to include more than 400 patients. And so hopefully we'll be powered to actually detect differences if there is one. I also want to mention the DANGER shock trial, which is a similar patient population, but randomizing patients to early Impella utilization versus standard of care. This trial, I think, highlights different difficulties in this field. This started as the DANSHOCK trial. It was a Danish trial with that patient population, and they had a lot of difficulty, meeting their enrollments and actually finding patients for this trial. So they actually brought in German sites to actually augment trial enrollment, and hence became the DANGER shock trial. But I think that highlights the ongoing difficulty in finding patients who can go into these trials. There at the end of the day is not a lot of equipoise in many centers. And so I think about the strategies moving forward when it comes to randomized trials in cardiogenic shock. And I think it's a little bit analogous to, are you a bunt single type of team, or are you a swing for the fences, and try to hit the ball out of the park, type of approach, where, I think a lot of the trials that have focused on this patient populations have been, let's apply this invasive therapy to, a somewhat heterogeneous patient population who's really, really sick and see what happens. And I think we need to, reevaluate that approach. I think there will be important trials with this sort of strategy that we have results from in the next couple of years. But I think more of us in the field are starting to realize that maybe we should be starting out with the bunt single and start getting randomized trials completed so we can build on that platform and sort of recognize sites where there is enough equipoise to actually randomize patients into these trials. So I want to talk a little bit more about those strategies. This is sort of a list of, a fairly complete list, I think, of unresolved issues in cardiogenic shock. And I highlighted a couple here that I want to talk about. Anti-coagulation therapies, systems of care, I think, is an important one. And then the use of invasive hemodynamics. When it comes to systems of care, I think it's important to recognize that there's a lot of value in that approach. And again, these are the National Cardiogenic Shock Initiative data. This is not a randomized trial, but this is a prospective study with fairly, I would say, a fair number of exclusions, but I think highlights the fact that when a rigorous algorithmic approach to the patient presenting with AMI shock, which involves early assessment of invasive hemodynamics, based on that, early intervention with device support. I think the data that continue to come from this effort will really start to shed important insights into the value of sort of that algorithmic approach, where you can see here, they really have demonstrated very nice, very impressive early results with more than 70% survival to discharge, where historically this patient population has seen more of a 50-50 in-hospital mortality or survival to discharge. The concept of the SHOCK team has really gained a lot of traction over the last couple of years. These are data from INOVA on the right and INOVA on the left and Utah on the right, that demonstrate sort of a pre and post launch of their SHOCK teams and the impact on outcomes. So again, not randomized data, but at least understanding the effect of changes within those institutions. In the INOVA cohort, particularly around AMI-related shock, where they began to see more and more of an algorithmic approach to that patient population, and those patients had significant improvements in their outcomes. This is data from Jack that comes from the cardiogenic shock, the critical care CCCTN, the critical care cardiology trial network, where those centers that contribute data to this registry, some of them had shock teams, some of them did not. And they analyzed differences between those distinct institutions and saw some important differences with respect to certain metrics. So in centers where shock teams were the standard, there was more utilization of PA catheters and invasive hemodynamic assessment. There was actually less utilization of overall circulatory support devices, but more of the devices that we consider more and more invasive. So more Impella, more ECMO, but as you can deduce from this difference, less balloon pump utilization for that patient population. And importantly, they did see a difference in mortality. And so again, none of these are randomized trial data, but I do think they highlight the fact that the approaches to this problem should not necessarily just focus on a specific device or a specific medication, and to really understand the value of strategies treating this patient population, I think will help to move the field forward. I want to spend a little bit of time talking about the role of hemodynamic monitoring, and Bobby gave a fantastic grand rounds last week on the way that we interpret data and how we know what we know in medicine. And I think this is an example of a study that was well-intentioned, but by misinterpreting this data, I think extrapolation of this data set into a different patient population has actually done some harm. So these are data from the ESCAPE trial, where patients were randomized. Essentially, these were warm and wet heart failure patients. These were not cardiogenic shock patients. And one of the most important exclusion criteria from this trial were essentially anybody that the investigators thought would benefit from a PA catheter was excluded from this trial. So talk about assessing a therapy in a patient population where you're not sure whether you're going to see a benefit. This is a pretty darn good example of that. We know the punchline from this trial with respect to their primary outcome of days alive out of the hospital. There was no difference between routine early use of PA catheters to manage this patient population, but there was increased risk, as we would expect with any invasive intervention. But what has unfortunately happened is that these data have been extrapolated to patients with cardiogenic shock, and people started to say there's no benefit from PA catheter monitoring. And I think that misses the nuances between trial populations. I think many of us who manage this patient population, believe that there's a lot of value in understanding invasive hemodynamic profiles. And one of the primary efforts of the cardiogenic shock working group has really been to focus on hemodynamic data in this patient population. Now, this was a retrospective analysis that we completed in the shock working group data set, where we looked at patients that had PA catheters and those who didn't. But more importantly, we looked at how that data was being utilized. And we looked at documentation around, whether there was really complete hemodynamic profiling versus whether there was a PA catheter in the body, but less complete profiling, for that patient population. And what we saw was that the more complete data sets that were being used, the stronger the association with improved outcomes. And in particular, this association between hemodynamic profiling and short-term survival to discharge, that was stronger and stronger the sicker the patients got, which I think speaks to what a lot of us practice at the bedside. It's not the relatively well patients that you want the hemodynamic data in. It's the ones who are sick, where you're going to use that data to make decisions around how to optimize their hemodynamics and hope that you're able to stabilize their condition. There are more and more evidences. There's more and more evidence in real world that this association is, I think, an important one, where this is data from the national inpatient sample, which highlights, again, an association, but an association between invasive hemodynamic monitoring and short-term outcomes. And this is one of several recent publications that really have highlighted, there does at least seem to be an association here for what that's worth. Why would a catheter that has no intrinsic benefit help change outcomes in this patient population? Well, obviously, I think even the best clinician has to accept the fact that we as a field are not that good at estimating hemodynamics. This is a very nice study from the University of Chicago, where everybody people on the healthcare team were essentially asked, from the intern all the way to the attending cardiologist, to predict what a patient's hemodynamic profile looked like going into the cath lab right before right heart cath. Blue is essentially when the estimation was spot on, and you can see here with respect to filling pressures, flow related indices, even the attending cardiologist was really not that great at estimating invasive hemodynamics. That's why you need to actually measure it. And the more that we understand about data from the SHOCK working group and the hemodynamic profiles, the more I'm really impressed at the prevalence of really that biventricular congestion profile. And if you aren't measuring that in real time, it's very, very hard to recognize and to actually target your therapies to those filling pressures. And I think one of the other important roles of the PA catheter in understanding invasive hemodynamics is the early recognition of right heart failure. These are data from the SHOCK working group looking at patients with MI-related shock, heart failure-related shock. It didn't really matter. Early recognition of right ventricular dysfunction or severe right ventricular dysfunction portended poor outcomes. And it's important to recognize this because we have tools that we can use now to actually support the right heart. And based on the data that I've showed you from the SHOCK working group, we've actually now started to design our first randomized trial, which will be one of a early invasive hemodynamic assessment, in a distinct patient population to really test in a shock patient population, is there a role for hemodynamic monitoring with a PA catheter? Obviously, I think the importance of timing and the timing of these interventions should be the target of a randomized trial. These are data from the Mayo Clinic where, in their CCUs, patients were examined for the presence of isolated hypotension, isolated hypoperfusion, or both. And I think the big take home here is that isolated hypoperfusion prior to the onset of hypotension actually had a worse prognosis than hypotension alone. And that speaks to the fact that looking for signs of hypoperfusion before the patient manifests overt hemodynamic compromise is critical, because we know that the window for intervention is not a long one. We know, for at least these are retrospective data really highlighting the fact that the so-called bailout strategy, waiting a long time to see if the patient's going to get better before you implement more aggressive therapies for patients with shock, in general, does not go well. I want to highlight another important aspect of this field, and that is, most of these devices come with the anticoagulants that we use. And this is very, very nice work that Will Grandin spearheaded, looking at the trade-off between bleeding and clotting in patients with ECMO. And many of us have always lived in fear of clotting complications for patients with these devices. And what Will saw when he actually dug into the data is that bleeding complications actually carry much more hazard than thrombotic complications in this patient population. And so I think, a randomized trial comparing, one anticoagulation strategy versus another would be a big step forward in this field. Again, maybe not swing for the fences, home run, but certainly would be, I think, important to recognize for this patient population. So I'm going to spend the last couple of minutes talking a little bit more about the cardiogenic shock working group. This is obviously one of the famous quotes from Deming, without data, you're just another person with an opinion. And I think historically in the field of cardiogenic shock, there have been a lot of people with opinions, and up until recently, not a whole lot of data. We unfortunately have had a lot of trouble with those randomized trials. But as we learn more and more from real world data sets and registries, I think we can start to move the field in the right direction, ask appropriate questions for the development of randomized trials that we will be able to complete. So this has grown from 4 centers. This was an initiative started by Naveen Kapoor. 4 centers has rapidly grown to about 20 and continues to grow. We've actually now expanded outside of the United States. We've onboarded St. Vincent's in Australia. We have partners in Germany. We had a call this week with partners in Italy. There's a lot of interest in Japan, and I think more and more of these sites will come on board so that we get really not just a US centric focus on this patient population, but really a global focus on understanding this disease. This is the sort of the outlook for the shock working group. We started as a retrospective registry. All of the data that I showed you came from the initial look at this registry, which again was all retrospective data with all of the caveats that come with that. We have moved into prospective, prospective registry, and with that, we're able to collect multiple time points throughout the patient's course in the ICU and start to understand how clinicians are making decisions for one intervention or another. And I think that will really help us to understand how to design randomized trials in this, that are nested in this registry so that they can actually be completed. I highlighted the PA catheter trial, which we are hopefully close to launching. Lastly, I think the value is going to be in numbers. In the first version of the registry, we had 1,700 patients. We've now completed the second version with 3,600 patients. We are launching the third version, which, as I said, will be prospective. And we're starting to get, I think, an accurate snapshot of what cardiogenic shock looks like with respect to the underlying disease processes. And hopefully we'll be able to learn more and more about the less well-studied etiologies of cardiogenic shock. This is sort of our outlook for the next couple of years. Obviously, we're focused on continuing to provide descriptive statistics. We'd like to move into predictive modeling, and in particular with a focus on machine learning and how to understand risk trajectories. We are launching clinical trials and really hope to be able to build out a pre-shock registry for patients with decompensated heart failure so we can understand more the transition from pre-shock to overt shock in that distinct patient population. So I'll stop here and have just highlight a couple points to conclude. The demographic of the CCU patient has, I think, changed and reflects more and more patients with decompensated heart failure, or at least less patients with AMI-related shock. And I think it's critical to understand those differences. They have impact when it comes to prognosis, but also response to therapy. I think as we get better and better with respect to risk prediction, we will start to understand what are the right questions and who are the right patients we should be targeting for our trials. As I showed you, randomized trials have been very, very difficult to complete in this field. But to rethink the strategy and really first build a knowledge base to understand this disease in greater depth, I think is the key to really starting to really change the outlook for this patient population. So have we changed the outlook in 2021? I think we've at least started to lay the groundwork so that over the next 5-10 years, we really will change the outlook for this patient population. Thanks very much for your attention. Happy to take any questions if we have any time.
Thank you very much, Reshad. That was fantastic. I think we have time for 1 or 2 questions.
Reshad, this is amazing talk. Just an awesome sort of overview of where this field is going quite rapidly, and incredible amount of work shining a light on this area now, and you've done a huge amount of that. I wondered if you could comment on, it seems like a lot of what the Cardiogenic Shock Working Group has done thus far and others has been to highlight phenotypes or profiles of risk, whether that's SCAI stage, the hemodynamic profile, or what Naveen has termed sort of hemometabolic shock parameters. But as you're now starting to think about randomized studies, I wondered if you could comment on the best ways to sort of bin patients or funnel them into appropriate trials, because even thinking about DOREMI and 15% of those patients were SCAI stage D and E, like, does it really make sense to randomize people like that to dobutamine versus milrinone? Like, we know more than we think we do, I think, at this point, in terms of the kinds of patients that could benefit from certain strategies. So how do we sort of funnel them into the right trials so we're not running trials that have little chance of success sort of based on our, a priori understanding of these conditions?
Yeah, I think you've highlighted one of the most difficult aspects of trial design for this patient population. So absolutely, finding that the patient that will not only potentially benefit from any intervention, but even more from a practical perspective, finding the patient population where there's enough equipoise at these centers to actually complete a trial is key. And while the SCAI staging classifications help us a lot in doing that, it's a little bit of a retrospective way to describe shock. So it's hard to know in one snapshot, which way that patient's going. And obviously we're talking about randomizing trials, randomizing patients, hopefully before they are in stage E. But I think, to be honest, the biggest challenge is going to be deciding where there's enough equipoise, for example, in a PA catheter trial, and a lot of sites where, by virtue of being in this registry, they rely a lot on hemodynamic assessments. And so, I think there are certain things that we are learning. Lactate, relatively simple, but a huge predictor in terms of trajectory. We're trying to whittle down the what we are willing to randomize, and that's where there's been a lot of back and forth when we talk about the who is going to actually be randomized in these trials. And when we go around the room on these calls and say to the investigators, would your colleagues randomize this patient? We get a mix. So to your point, one of the biggest problems has been finding the patient, who's potentially going to benefit, but then even more than that, recognizing that may not actually be the patient population where there's enough equipoise to complete a trial. So marrying those two, I think, is the challenge that we're running up against right now.
Excellent. Well, that was a wonderful discussion of some of the challenges that certainly our heart failure group and many of us face on a daily basis. So thank you very much, Reshad. We very much enjoyed that talk. We'll wrap it up at this point so folks can get to their interviews, and we'll see everyone next week. Thanks.
Thanks.